So, hello to everybody. Welcome. You are attending the Anesthesia and Analgesia Patient Blood Management webinar. And this is Friday, September 9th, 2022. I want to welcome you all to this Anesthesia and Analgesia International Anesthesia Research Society webinar to promote our September 2022 special themed issue in patient blood management. My name is Susan Goobie. I have the pleasure and the honor to be the Anesthesia and Analgesia's executive section editor to the patient blood management section. And I was guest editor for the September patient blood management themed issue. And I hope that these four physicians who've been invited, they're expert clinicians, researchers, and authors, and they've been selected to present a snapshot of their manuscripts highlighted in the new patient blood management themed issue. And I hope that you will enjoy the next four talks. I'm going to introduce each of them, and then we'll have their presentations to follow, followed by question and answers after. This webinar and the special Anesthesia and Analgesia patient blood management themed edition will hopefully bring all of us who are very passionate about patient blood management all around the world together to promote patient blood management as a new standard of care to optimize blood health. And so first, it gives me great pleasure, this is me, to introduce Dr. Stacey Valentine. Dr. Valentine is an associate professor and vice chair for academic affairs in the Department of Pediatrics, Division of Pediatric Critical Care, University of Massachusetts Medical School. Dr. Valentine focuses her research on improving pediatric patient blood management through creating guidelines for red blood cells, platelet and plasma transfusions, and hemostasis. She has co-chaired the Pediatric Critical Care Transfusion and Anemia Expertise Initiative, or TAXI, and she was executive committee member for the TAXI CAB, which is the Controlled Avoidance of Bleeding Consensus Series. She serves on the board of directors for the Society of the Advancement of Blood Management, which is one of the affiliated societies for anesthesia and analgesia and IARS, and she's an active member of the scientific committee of SABM. And so welcome, Stacey. Next, we will have Dr. Greg Hare, and he will be presenting his work on On Track, a 20-year history of successful coordinated province-wide patient blood management program in Canada, lessons learned and goals achieved. Dr. Hare is a staff anesthesiologist at St. Michael's Hospital, Unity Health in Toronto, Canada, and a professor in the departments of anesthesia, pain, and physiology at the University of Toronto. His clinical focus is to develop multimodal and interprofessional approaches to define mechanism of anemia-induced morbidity and mortality, and to design novel treatment strategies to prevent these adverse outcomes. And Dr. Prakash Patel will be following and talking about an update on applications and limitations for perioperative tranexamic acid. This is one of the themed issues in our patient blood management. It's actually available as a free download. And he is a cardiac anesthesiologist and associate professor at Yale University in New Haven, Connecticut. Dr. Patel completed his medical training at Jefferson Medical College and his anesthesiology residency and cardiac fellowship at the Hospital of University of Pennsylvania. Dr. Patel has strong interests in blood conservation. He has led several initiatives to create an algorithmic approach to blood management and transfusion. And so we welcome him. And then finally, we will also have Dr. Julie Wyrobek talking about update on applications and limitations of TXA. And she is a cardiac anesthesiologist and associate professor at Yale. Here she is, a cardiothoracic anesthesiologist at the University of Rochester Strong Memorial Hospital. She's an assistant professor director of the anesthesia residency and the associate program director of cardiothoracic anesthesiology fellowship. Her research interests are concentrated in the area of mechanical support devices, including hemodynamic management of patients with left ventricular support devices undergoing non-cardiac surgery and echocardiographic assessment of right ventricular failure. And so I wanted to make the announcement that the recordings of this and past ANA webinars will be available on the IRS YouTube channel. And also all members who are registered will get a link to the recordings of these webinars immediately following. And we will have question and answers at the end. Please use the Q&A button on the Zoom taskbar. So without further ado, I hope you enjoy the following presentations by our experts in patient blood management. Thank you.
A published manuscript, Transfusion Strategies for Hemostatic Blood Products in Critically Ill Children, a narrative review and update on expert consensus guidelines. I have no financial relationships to disclose. I want to take a moment to thank my co-authors, Jill Chalette and Susan Goobie, for their extensive contributions and wonderful expertise. To provide some background, hemostatic blood products, platelets, plasma, cryoprecipitate, and recombinant products are transfused in children undergoing surgical procedures to treat coagulopathies, to manage bleeding, and prevent bleeding complications. Our manuscript provides current literature to support hemostatic transfusion decision-making in the perioperative setting, and I'll be focusing on plasma and platelet transfusion decision-making in recent guidelines, focusing mostly on plasma and platelets. When thinking about platelet and plasma transfusion in children, there are two large point prevalence studies focused on the epidemiology of plasma and platelet transfusions in critically ill children. After screening admissions in 101 PICUs from 21 countries, Karam and colleagues reported that 3.4% of critically ill children received plasma transfusions, 1/3 of whom had no bleeding and no planned procedures. In a similar study involving 82 PICUs from 16 countries, the point prevalence of platelet transfusion was 3.3%, with the majority prescribed prophylactically to non-bleeding children. Those most commonly transfused are undergoing cardiac surgery, regarding cardiopulmonary bypass, supported by ECMO, and with oncologic diagnoses. Adverse reactions directly related to blood product transfusions are 1.5 to 2.5 times more common in children under the age of 1 year. Plasma and/or platelet transfusions are associated with adverse reactions, including febrile, hypotensive, allergic, and anaphylactic reactions, transfusion-related acute lung injury, transfusion-associated circulatory overload, and transfusion-related immunomodulation. In a retrospective analysis of transfusion reactions across 44 hospitals, 35 adult hospitals, and 9 children's hospitals, transfusion reaction rates were overall higher in children, 539 versus 252 per 100,000 transfusions. In 2020, in the Serious Hazards of Transfusion report from the UK, platelet transfusions are the most common cause of adverse events in children. Plasma and platelet transfusions are also associated with increasing morbidity and mortality in critically ill children. In a prospective cohort of 831 critically ill children in a single institution, plasma transfusion was independently associated with the development of organ dysfunction, nosocomial infections, and longer PICU length of stay. Increased morbidity and mortality following platelet transfusions in critically ill children has also been reported. There's been an increase in mortality for every additional standard dose of 10 cc's per kilo of platelets administered. In a randomized controlled trial of platelet transfusion thresholds in critically ill preterm neonates, the study demonstrated that a restricted transfusion threshold of 25,000 was associated with less bleeding and/or mortality as compared to a liberal threshold of 50,000. When considering transfusion of hemostatic products in children, one must consider special considerations, or one must have special considerations. Coagulation factor levels in preterm and full-term infants are approximately half of adult levels, and they slowly increase with age, not reaching adult indices until 16. However, these differences do not increase bleeding risk, and in infancy, especially in infancy, as natural anticoagulants, protein C, protein S, and antithrombin are also decreased at birth. Standard measures of coagulation, such as prothrombin time and activated partial thromboplastin time, may be physiologically prolonged in the infant and young child without any correlation to bleeding risk. Despite morbidities, very little guidance exists to direct plasma and platelet transfusions. Recommendations have been developed by various groups. These are from the ABB, but questions remain: how to transfuse with clinically relevant bleeding? What about prior to bone marrow biopsy, LP or CBL? Which prompted the formation of the Transfusion and Anemia Expertise Initiative Control Avoidance of Bleeding, TAXI-CAB, which was modeled after the TAXI conference, and it aimed to create evidence-based guidelines, and when evidence is lacking, expert-based consensus on patient blood management strategies for clinicians caring for children, aimed to optimize hemostasis and minimize blood loss. The populations of focus included massive hemorrhage, trauma, invasive procedures outside the operating room, following non-cardiac surgery, liver failure transplantation, ECMO, and following cardiopulmonary bypass. The guideline group systematically evaluated the evidence and created evidence-based recommendations using GRADE methodology, and when evidence was lacking, created expert consensus statements. Important points of management were addressed using good practice statements. The first general good practice statement: when deciding to transfuse plasma and/or platelets, it is good practice to monitor not only hemostasis, but also the overall clinical context, while considering the risks, benefits, and alternatives to transfusion. The TAXI-CAB group also created clinical decision trees to guide transfusion decision-making of platelets and plasma. To orient you to this decision tree, which I will be showing you throughout the remainder of this presentation, the first branch is to determine if the patient is having massive hemorrhage, moderate to severe bleeding, or minor or no bleeding, and that is defined at the bottom of the figure. There are decision trees for both platelets and for plasma. Thinking about the first group in massive hemorrhage, first we need to define massive hemorrhage, which is generally considered transfusion of greater than 40 cc's per kilo of blood products in a 24-hour period. Etiologies of massive bleeding vary, with one recent prospective cohort describing the causes as 46% traumatic, 34% operative, and 20% medical. Current recommendations for blood product administration in children with massive hemorrhage are based on adult data. Transfusion ratios, red blood cells to plasma to platelets of 1 to 1 to 1, 2 to 1 to 1, have only been studied retrospectively in children. Two recent expert consensus conferences, the Pediatric Transfusion Anemia Expertise Initiative and TAXI-CAB, developed recommendations for massive hemorrhage in children. They suggest a resuscitation strategy of red cells, plasma, and platelets following the adult data of 1 to 1 to 1 to 2 to 1 to 1. Noting that fixed ratio-driven approach may lead to inappropriate or unnecessary transfusions. This is depicted here in the decision tree. In trauma patients, severely injured patients with hemorrhagic shock can develop coagulopathy within minutes of injury, known as trauma-induced coagulopathy. There is no universally accepted definition of trauma-induced coagulopathy in children, however. And while there is insufficient high-quality evidence, TAXI-CAB experts created these recommendations. In neurologically stable, critically ill children with severe trauma, moderate or severe traumatic brain injury, or intracranial hemorrhage, platelet transfusions may not be beneficial if the platelet count is greater than 100,000. Platelet transfusions may be considered if an intracranial pressure monitor is required in a child with a platelet count less than 100,000. And plasma transfusion may not be beneficial before ICP monitor insertion if the INR is less than or equal to 1.5. And the platelet transfusion thresholds are depicted here in the decision tree. And the plasma transfusion thresholds are depicted here. When considering transfusion of platelets and plasma for invasive procedures outside the operating room, taxicab experts developed recommendations for procedures with a low risk of bleeding, peripheral IV insertion, central venous catheter removal, bone marrow aspirate, and biopsy. Prophylactic platelet transfusion may not be beneficial and may cause harm. In those undergoing a lumbar puncture, platelet transfusion can be considered if the platelet count is less than 20,000. Prophylactic platelet transfusion may not be beneficial for platelet counts greater than 50,000. And plasma transfusion, no benefit if the INR is less than or equal to 1.5 times baseline, an unclear benefit if the INR is between 1.6 and 2.4, and to consider transfusion if the INR is greater than or equal to 2.5 times normal. And again, in the decision tree, the decision for platelet transfusions with invasive procedures outside the OR, IV insertions, CVL removal, and bone marrow biopsy are here. And invasive procedures outside the operating room and IV insertion, CVL removal, bone marrow biopsy are here for plasma. Children following surgery are at risk for bleeding and often receive platelet transfusions. The type of surgery, site, and pattern of bleeding, risk factors including defects in platelet function, coagulopathy, DIC, and risks associated with transfusion should all be considered. For children undergoing non-cardiac surgery with minimal or no active bleeding, following this surgery, postoperative patients, platelet transfusion can be considered if the platelet count is less than 20,000. Plasma transfusion based on laboratory values may not be beneficial and may cause harm. In those with moderate bleeding, platelet transfusion can be considered if the platelet count is less than 50,000, and plasma transfusion can be considered if the INR is greater than or equal to 2 times normal. And the platelet transfusion thresholds following non-cardiac surgery can be found here, with less than 20,000 if there's minimal, and less than 50,000 if there's moderate to severe bleeding. While the guidelines for transfusion of plasma are here, if there's no or minimal no bleeding, the recommendation is to not transfuse, and if there's moderate or severe bleeding, the recommendation is to transfuse if it's more than 2 times more. In liver failure or liver transplantation, hepatic failure is characterized by loss of well-controlled complex hemostatic system. The physiologic controls of the clotting and fibrinolytic systems are both lost in liver failure, resulting in dysregulation of hemostasis. Also, the heterogeneity of coagulation profiles in response to transfusion patients is complex. When considering transfusion, these patients, it's helpful to have a historical background that it was historically thought to have these patients have high risk of bleeding, but epidemiologic studies have shown that they're more prone to thrombosis, and INR does not predict bleeding. Transfusions of any blood component associated with increased mortality, decreased graft survival, and hepatic failure. Consensus recommendations in pediatric acute liver failure with the absence of moderate bleeding or severe bleeding in prophylactic plasma and platelet transfusions may not be beneficial and may cause harm, and this is shown here. Platelet transfusions and thrombocytopenia are each associated with worse clinical outcomes in pediatric ECMO. In the absence of clinically significant bleeding, if the platelet count is greater than 100,000, prophylactic transfusion is unlikely to be beneficial. If the patient is bleeding in ECMO, the consensus recommendations are transfused until the platelet count is greater than 100,000. And these can be depicted here. In cardiopulmonary bypass, it's become increasingly recognized that standard coagulation tests were not designed to inform perioperative coagulopathy or guide administration of blood products on cardiopulmonary bypass. And in this population, there's insufficient evidence to make recommendations for plasma and platelet transfusion. Patients with clinically significant active bleeding should receive judicious and targeted platelets and plasma transfusions guided by the patient's clinical status, standard coagulation tests, and viscoelastic testing. The overall goal is to provide the lowest dose of platelets and plasma necessary to control or treat active bleeding. For patients without significant bleeding, clinical judgment is required for platelet and plasma transfusion decision-making, and these are depicted here. In summary, the Transfusion and Anemia Expertise Initiative created guidelines for transfusion decision-making of platelets and plasma. The decision trees allow clinicians to walk through, determined based on the patient population, whether the patient has massive hemorrhage, moderate to severe, or minimal to no bleeding, to help decisions with transfusion. Thank you.
Good morning, and thank you for the opportunity to present our data and experience of our patient blood management program, referred to as ONTRAC, or the Ontario Nurse Transfusion Coordinator Program, which has been initiated by John Friedman. And I'd like to acknowledge my authors, as well as Dr. Susan Goobie, for the opportunity to present this work to you today. One of the interesting numbers that I found through assessing anemia and the importance of the red blood cell is this estimate that red cells make up about 70% of all human cells in our body, which emphasizes the importance by their sheer volume of number of red blood cells in our normal physiology. And over the decades, physiologists have tried to understand the important function of red cells, which are multiple, but one of the key functions that we understand is the red cell's ability to carry oxygen and deliver oxygen to tissue. And this governs the functional of cardiac output or global oxygen delivery, as well as specific tissue demands. So if we review the red cell, one of its primary functions, as we understand it, is to deliver oxygen to tissues. And the importance of delivering oxygen to tissues is that allows the cell through the respiratory process to generate adenosine triphosphate, or ATP, which is the currency of energy upon which each cell maintains its function. And this allows organs of importance, such as the heart, the brain, the kidney, and all other cells, to maintain their cellular integrity and perform specific functions within the body to maintain our health. The problem with that dynamic is that with a lack of red blood cells or anemia, there's evidence of problems that we are addressing both in perioperative medicine and in patients within the world. And these are data that shows that anemia, or the lack of red blood cells, is a global health problem. An estimated 1/3 of the world exists in the anemic state due to substrate deficiencies, iron deficiency, parasitic disease. And not only does this affect the patients that we see for perioperative care, but it also is a leading cause of disability in children and young adults, suggesting that this is a really large magnitude problem. If we focus on the patients that we see, this is a large systematic review and meta-analysis of a number of studies looking at patients coming for cardiac surgery. And as you can see, the estimate of the prevalence of anemia is about 20% in this population. And those patients coming for cardiac surgery who are anemic have an evidence of an increased mortality, kidney injury, stroke, and infection. So bad outcomes occur in anemic patients by association. If we look at patients undergoing cardiac and non-cardiac surgery in the ISOS study, which is a prospective study in almost 40,000 patients assessing outcomes if patients stayed 1 day in hospital as a result of their procedure, you can see again that about 30%, or that 1/3 of patients, is anemic coming for surgery, and that their incidence of adverse outcomes, including mortality and serious adverse events, goes up in anemic patients. And if you look at the blue line here shown on this graph, the interesting thing about here is the inflection point for adverse outcomes occurs at a surprisingly high hemoglobin level, near 12 grams per deciliter, indicating that these patients, even at higher hemoglobins, are still at risk if they are in the anemic range. What we don't understand is the pathophysiology, or the mechanism by which anemia leads to adverse outcomes within the cells and organs and mortality. This is a schematic that we've recently published indicating that there is a connection in terms of association between these outcomes, but we really don't know the the direct link in the causal mechanism as of yet. But what we do understand is that in our clinical practice, anemia is a risk, and we've known this for quite some time, but also treatments such as red blood cell transfusion also are associated with risks. And what our global sort of approach to these patients is to try and balance these risks to optimize patient outcome in anemic patients. And I haven't got time in this presentation to go through all of those approaches, but if we look at this again, summary slide from our review article, there are different approaches, including appropriate red blood cell transfusion, combined treatment of anemia, including erythrocyte stimulating agents and iron, and even intravenous iron, which is now becoming more available and prevalent and safe. These are all modalities which have been shown to have improved outcomes. But what the pinnacle of this treatment process is to have multimodal blood management, taking all aspects of that anemic patient to treat them over time to improve their hemoglobin, reduce the risk of transfusion, which has been shown, but the ultimate goal would be to improve outcome in these patients. And the data there is less clear. I'd like to stop and acknowledge that there are many practitioners and healthcare professionals that have championed blood management over the last several decades. And I'd like to acknowledge Hare, who's been a colleague and a great mentor, and somebody who has shown us the way in terms of how these programs can work. I know there are many others, and I'd like to acknowledge all of them. But in terms of Dr. Chandra's case, here's an early study published in 2010, which shows if you look at the cohort of their patients undergoing bypass surgery, and you have patient blood management or not, the patients have a significantly reduced transfusion rate, reduced mortality, and reduced serious adverse events if they've gone through a blood management program. This is not causal, it is associative data, but is strongly supportive of the value of blood management. I'd like to also acknowledge another champion more locally, John Friedman, who initiated through his work as the head of our transfusion program at St. Michael's. But what he did was initiate a province-wide system, as we'll describe to you in detail, called OnTrack, which is a network of 25 hospitals. It's the only program in Canada that's been fully funded to target and treat patients who come to surgery anemic in a broad and multidisciplinary way. And here are some early data published in 2008, which shows there's a benefit of this in terms of transfusion avoidance in both knee surgery and CABG. So in more detail, the Ontario Transfusion Coordinator Network program is a group of 25 centers, 14 in the Greater Toronto area, because that's a huge population. And these 25 centers were chosen because they comprised about 3/4 of the blood transfusions in Ontario, several hundreds of thousands of transfusions a year. And we wanted to target this large network to introduce a transfusion coordinator, usually a nurse, who would have a champion, who was a champion, and who also would have other collaborative champions, including anesthesiologists, surgeons, transfusion medicine specialists, and others to try and optimize patient treatment and minimize transfusion. So what did we achieve, or what has been achieved by this large collaborative network? Well, these are two targeted index cases that are followed. This is single knee arthroplasty. The data for primary hip arthroplasty are similar, and coronary bypass surgery. And what you can see here is in 2002, at the index year, we started a transfusion rate of about 25%, and this decreased steadily over the next decade until a significant drop happened again in 2012. And to me, this is coinciding with our increased utilization of tranexamic acid, but that's not proven. But then again, you see a continual improvement in transfusion down to a rate near zero. And our transfusion rates for knee and hip arthroplasty of a primary nature are now near zero, and that's true for many other centers as well. So we've had great success in taking these patients and managing their blood management and minimizing transfusion to almost not needing that resource. How about cardiac surgery? Well, cardiac surgery is a much different procedure. We started with a transfusion rate around 60%. And as you can see, there's that first decade of decrease, and then it plateaus to a transfusion rate of 20 to 25%. Some people regard that as a failure, that we haven't taken it down to zero. But I think more specifically, as we get more data about these patients, they're complex patients, their transfusion requirements are higher, and in some cases, as indicated by subsets of the TRIX3 database and other trials, in many cases, a more liberal approach for transfusion should be maintained as a potential life-saving modality in these patients. However, I still think this is a success rate to bring our transfusion rate from 60 down to 25. The other thing that's interesting and often not believed by many people, when you look at the data, the thing that occurs is in all cases, the increase in transfusion rate occurs at a very high hemoglobin rate. Now, these are Canadian numbers, 110, 130 grams per liter, but in your terms, 11 to 13 grams per deciliter. But if we look at when the transfusion rates increase, in knee surgery here, you go from 1% to 5% below 11 or 110. Cardiac surgery or cardiovascular surgery, much higher hemoglobin thresholds, below less than 130. And perhaps in gynecological surgery in young women having transuterine myomectomies, where we want to target a 0% transfusion, maybe that's even higher. So the surprising thing is both the transfusion rate and adverse outcomes occur at quite high hemoglobin concentrations. How do we approach this? Well, again, this is data that's consistent with other published data. You have to use more than one, or you're optimal to use more than one method of blood conservation. And this shows the baseline improve with one modality, but if you use more modalities and approach things like treatment of iron and using a lower transfusion threshold, or iron and erythropoietin or other approaches, delaying surgery, you again will improve your success at reducing transfusions. Now, the hard link then is how do we link this lack of transfusion with improved outcomes? And here's one that's more of a composite, is length of hospital stay. So if you look across all of our index cases, a number of different types of cases, from hip arthroplasty to cardiac surgery and gynecological surgery, in each case, the patients in our system that did not get transfused had a shorter length of stay than if you did get transfused. And you can see when patients are transfused, there's a much bigger spread of the length of stay. Now, this may be in part because once you commit to a transfusion, if it happens at the end of the day, you just bought somebody another day in hospital. But there perhaps are multiple factors which show that transfusion is associated with a longer length of stay. And this is an important target to try and reduce healthcare costs, but also improve patient outcomes. More specifically, if we look across the data of time and looking at knee, hip, and CABG surgery, patients who were not transfused have a lower infection rate. And again, this is not a randomized trial, so it's associative data over time. But again, the suggestion, or it supports the hypothesis by treating patients, avoiding transfusion, that infection rates are reduced in these index cases. And I think that starts to speak to an important patient outcome that we would all value. So decreased length of stay, important for patient care and cost. Decreased infection, also important for patient care and eventually cost as well. Now, here's the final data slide that I'd like to show. And Dr. Friedman has looked at this, and in justifying the program has to constantly demonstrate that there is cost efficient to the ministry to allow the funding to be maintained. And this is a relative comparison to the baseline cost. So if where we started, the cost of the program is estimated about $3 million. The cost of the savings per year of the blood and other products that we'd have to buy is about $14 million. And the cost of administering those and all the associated costs of length of stay and other elements is estimated across the province through the index cases to be about $37 million savings. So you might argue that this is, if we compare to baseline, we're taking a 20-year experience, but still the cost reduction or cost efficiency is supported by these data. So not only improving outcomes, reducing transfusion, but it seems to be that we can do it in a cost-efficient manner. So what lessons have we learned? First of all, as you all will know, changing culture around any treatment, but for sure around red blood cell transfusion is not easy. People have very fixed and strong concerns. They have their clinical experience. And so we need to show data that these changes can occur and can occur in a positive nature. So data always speaks louder than words. This program, one of the strongholds of this program is that you need to have collaborative communications at all levels of healthcare, including administration, nursing, medical individuals. Anyone involved with the care of these patients need to be involved and have open communication, and a local champion of any sort. Often the nurses in our programs are the coordinators that are the champion, but they're supported by anesthesiologists, surgeons, transfusion medicines, and other practitioners, healthcare practitioners that support this global outcome and program. So in summary, we've shown that you can develop a multi-center province-wide or large territory-wide management program. It's achievable. It's associated with productive reduction in allogeneic red blood cell transfusion rates, which is a resource, an important resource to save and to regulate. And that patients who did not receive red cell transfusion had evidence of reduced length of hospital stay and infection rate. Again, two outcomes, I think, which are positive in terms of our treatment of these patients. And cost efficiency has been demonstrated in terms of the value of this program over time. So in summary, I'd like to thank my colleagues who helped produce this, to John Friedman, Katerina Pravensky, Alana Howell, who provided great leadership in this area. And finally, to Susan Goobie, who showed leadership in maintaining the emphasis on blood management as an important program in our healthcare systems to maintain. It's been a great opportunity to present this data to you, and I look forward to your questions. Thank you very much.
Hello, everyone. My name is Prakash Patel. I'm a cardiac anesthesiologist at Yale University. I want to start by thanking IARS and ANA for allowing us to participate in this webinar, which is based on the September PBM-themed issue of ANA. My topic for today is going to be an update on tranexamic acid use in cardiac surgery. And our discussion comes from this review article, which is in the PBM-themed issue, Update on Applications and Limitations of Perioperative Tranexamic Acid. Just to begin, I have no disclosures to mention. Very briefly, let's just remind ourselves how TXA works. You'll remember that normal fibrinolysis involves plasminogen becoming plasmid after binding to a lysine residue on fibrin, and this happens with the help of tissue plasminogen activator. On the right side of this image, you can see that in the presence of a lysine analog such as TXA, the TXA binds to plasminogen, preventing binding to fibrin, and therefore no conversion of plasmin and ultimately decreasing fibrinolysis. Now, given its efficacy in decreasing bleeding, it's not surprising that TXA use is established in a broad range of perioperative settings, both the adult and pediatric population. In fact, potential expansion of TXA to all patients undergoing non-cardiac surgery has even been investigated very recently. The POISE-3 trial was a randomized trial of over 9,000 patients receiving either TXA or placebo in a variety of general surgery cases. And when looking at a composite bleeding outcome, it was not surprising that the cumulative risk of a bleeding event was less with TXA compared to placebo, demonstrating superiority of TXA in decreasing a bleeding event. Now, in that same trial, they found that when looking at a composite of cardiovascular outcomes, including thrombotic events, there was a very small suggestion that perhaps TXA is not as safe to use, and they were unable to establish non-inferiority when compared to placebo. And it's findings like these that lead us to question the routine use of TXA and why TXA still gets so much attention. For a drug that was first used clinically over 60 years ago, we're still studying it today on a regular basis because of these ongoing concerns, especially with safety. Now, these concerns exist in all the subspecialties that are listed here, but in the interest of time, I'm going to focus now on concerns in the cardiac surgical setting. Now, before we get to that, let's remember that lysine analogs like TXA get the highest possible recommendation in cardiac surgery. The 2021 blood management guidelines again give a class 1A recommendation, meaning that benefits far outweigh harm. Now, despite this recommendation, we still worry about things like dosing and renal failure, although this was discussed a few years ago with a new dosing regimen proposal using pharmacokinetic investigations. We also had concerns about TXA's potency, leading to thrombotic risk, especially in coronary patients. But that too was addressed in the landmark Atticus trial from 2017, where we saw no difference in graft patency in coronary patients who received TXA compared to those who did not. What remains unanswered are questions regarding optimal TXA dosing for efficacy. How aggressive should we be with dosing to maximally decrease bleeding? Other questions include safety concerns, specifically for the prevention of seizures. And I put these two concerns together because with higher doses, of course, comes higher risk. Now, to answer these questions of dosing and seizures, we can look to this recent meta-analysis that compared a high dose of TXA to a low dose of TXA in the cardiac surgery population. 49 studies, over 10,000 patients, and you can see in the table, they looked at a bolus-only approach where 50 milligrams per kilogram was used as a cutoff, and they looked at a bolus plus infusion approach where 10 milligrams per kilogram was used as a cutoff. And what the investigators find is that when looking at transfusion rate, low dose protocols seen on the top of this figure were no different than high dose protocols seen on the bottom as far as decreasing the need for blood transfusion compared to control groups. Now, this is for the bolus only group, and they found the same result when looking at the bolus plus infusion group. So with that, they go on to conclude that intravenous high-dose TXA does not further decrease transfusion rate when compared with low-dose regimens, but high-dose TXA use is associated with a 4.83 times higher risk of seizures. So we can summarize this study by saying that low-dose TXA is just as effective and has a better safety profile. Now, you would think that this kind of information would be convincing enough for us to avoid high-dose TXA use, but we have to remember that the conclusion is based on comparisons of each dosing regimen to a placebo or to a control, not based on a direct comparison of high dose to low dose TXA. So fortunately for that, we have the results of the optimal study. This is a study that was just published 2 months ago. It was a multi-center randomized double-blind trial looking at over 3,000 patients, again, looking at 2 dosing strategies for TXA use in cardiac surgery. And you can see that dose 1 was the more aggressive high-dose regimen, and dose 2 was the less aggressive low-dose regimen. And from an efficacy standpoint, which was based on the need for a red blood cell transfusion, there was a 21.8% incidence in the high-dose group compared to a 26% incidence in the low-dose group. While only a modest difference, this difference was enough to result in superiority for the high-dose group in decreasing transfusion. And let's keep in mind that this result is different than what we saw in the prior meta-analysis here. When you're comparing the 2 doses directly to each other, high dose actually is more efficacious. As far as safety endpoint in this study, they looked at a composite of mortality, seizures, renal dysfunction, and thrombotic events. And when comparing the 2 groups in a one-sided non-inferiority design, they find that high-dose group does not have a higher rate of adverse events. Again, this is contradictory to what we're seeing in the prior meta-analysis, specifically in regards to seizures. So with these 2 recent studies, how do I summarize to you the TXA update that I want to provide you in cardiac surgery? We basically saw that questions still exist on optimal dosing for efficacy and safety, still have unanswered questions. So depending on the trial design, we saw that high-dose TXA may or may not be superior in decreasing bleeding and transfusion, and high-dose TXA may or may not come with a higher risk of seizures. Ultimately, ongoing investigation is still warranted. We need to look at the type of surgery, whether it's open chamber versus closed chamber. We need to also incorporate certain patient risk factors, perhaps even consider individual TXA titration, which has been suggested. And with so many areas to look at, I'm hoping that our next update is going to provide us with some more answers on this already well-established drug. So with that, I'm going to end there. I want to thank you for your time, and I'm going to now introduce to you Dr. Julie Wyrobek, who's going to be continuing our update on TXA, looking specifically at the trauma population. Thank you.
Good morning, everyone. My name is Julie Wyrobek, and I'm from the University of Rochester. In this webinar, we're going to continue our discussion of TXA, now in the trauma population. I have no disclosures. Here's an outline of today's talk. We're going to review 3 landmark trauma studies, the CRASH 2, MATTERS, and CRASH 3 trials, discuss acute traumatic coagulopathy, and then interpret these studies based upon the latest fibrinolytic data. Now, the CRASH 2 trial was an international randomized controlled trial of TXA in over 20,000 patients coming into the hospital who had or were at risk of significant bleeding. Patients were included in the study if there was an uncertainty as to whether they should get TXA. The non-placebo group received 1 gram of TXA over 10 minutes and then 1 gram over 8 hours. The primary outcome was mortality within 4 weeks. The investigators found that all-cause mortality was significantly reduced in the TXA group with a relative risk of 0.91. Interestingly, there was no significant difference in the number of blood products the 2 groups received, and only half in each group received any blood products at all. There was no significant difference in thrombotic events between the 2 groups. The other major finding of this paper was there seemed to be an optimal time window of less than 3 hours in administration of TXA. In fact, when looking specifically at death due to bleeding, the graph seen here, treatment over 3 hours was associated with an increased risk of mortality. The next large trial to come out was the MATTERS trial. This was a retrospective analysis of combat patients who received blood after trauma and compared those who received TXA to those who did not. They found that those who had received TXA had a lower 48-hour and in-hospital mortality. The benefits of TXA were more pronounced in the subgroup that had to be massively transfused. Now, unlike the CRASH-2 trial, they found significantly higher rates of DVT and PE in their TXA group. The CRASH-3 was published in 2019 and was an international randomized controlled trial of TXA in over 12,000 patients with traumatic brain injury who presented within 3 hours of injury and had a GCS of 12 or lower or an intracranial bleed. The non-placebo group received 1 gram of TXA over 10 minutes and then 1 gram over 8 hours. The primary outcome was head injury-related death at 28 days. They found no statistically significant difference in their primary outcome, even after excluding patients with very poor prognoses. In their sub-analysis, there was a relative risk of 0.78 in patients with mild to moderate head injury. They, like the CRASH-2 trial, found that earlier treatment was more effective than late treatment in patients with mild to moderate head injury. They found no significant difference in vascular occlusive events between their two groups. So when we talk about acute traumatic coagulopathy, it is by no means all the same pathologic process. In fact, our most recent understanding puts patients into 3 phenotypes: a hyperfibrinolysis group, a physiologic fibrinolysis, and then a fibrinolytic shutdown group. There are patterns that emerge from these phenotypes. The hyperfibrinolysis group tends to be younger patients, presenting with penetrating trauma and shock, and much more likely needing massive amounts of blood. Conversely, the fibrinolytic shutdown phenotype tends to be older, have blunt or soft tissue trauma, associated with late mortality suffered from multi-organ failure. So based upon our knowledge of TXA as an antifibrinolytic, it would theoretically, preferentially, help the hyperfibrinolytic group. The graph on the left highlights our first conundrum when discussing TXA and trauma. 1, patients presenting after trauma are much more likely to present with the fibrinolytic shutdown group. When looking at mortality, both extremes in coagulopathy have worse outcomes. Hyperfibrinolysis at risk of early death, fibrinolytic shutdown at risk of later death. To make matters even more complicated, the phenotype may change over time. The graph on the right shows that after about 3 hours, all patients who presented with hyperfibrinolysis either switched into another phenotype or died. Now remember that in the CRASH-2, they found that 3 hours was the inflection point in their odds ratio, similar to the time point that these patients with hyperfibrinolysis started to convert into other phenotypes. This fantastic retrospective analysis published in January in Anesthesiology, which I highly recommend reading, ROTEMs were measured at admission and at 24 hours and compared those who did to who did not receive TXA. They first demonstrated how in the TXA group on the right, the hyperfibrinolysis phenotype was virtually non-existent, and the fibrinolytic shutdown group was significantly larger. They also found that the change in phenotype over time can be a predictor of outcome, with those who had delayed onset and persistent fibrinolytic shutdown having the largest risk of late mortality. Lastly, they demonstrated that TXA was associated with better early mortality, but found no difference in late mortality among their population. Now, despite this and all the previous studies, there are still so many unanswered questions regarding TXA use in trauma. First, we still do not have a clear mechanistic pathway delineating how TXA influences mortality without affecting blood product administration or surgical referrals in the CRASH-2 trial. Secondly, should we be using TXA only in patients with hyperfibrinolysis, even though the vast majority of trauma patients and likely study patients present with fibrinolytic shutdown? In fact, what role, if any, does TXA have in patients with fibrinolytic shutdown in trauma? And lastly, while we have an idea that earlier TXA and smaller doses benefit patients, the optimal timing, dosage, and the appropriate recipient injury population still need to be determined. So to sum up the main points of this webinar, TXA use in trauma is now well established after the CRASH-2, the CRASH-3, and MATTERS trials. It is recommended that if given, it should be given within 3 hours of injury, and perhaps more likely to positively influence those with penetrating trauma and large transfusion needs, or traumatic brain injury that is mild to moderate in nature versus severe, and should certainly be just one part of a multimodal resuscitation plan. While concerns of thrombotic and seizure risk are certainly valid, large randomized controlled trials have concluded that TXA is safe to give at the dosages currently tested. Thank you very much.
So I wanted to welcome back all our panelists and hope you enjoyed that last hour of interesting talks. We have about 15 minutes for questions. I wanted to tell all the participants that in the chat, you can find the link for the anesthesia and analgesia patient blood management themed issue that was put there at the very beginning of the chat. And I would encourage you to go there and look at all the great articles, some of them discussed here and others of interest surrounding patient blood management. As I said, I hope this all leads everybody to sort of think about patient blood management as a new standard of care. And, you know, all of these people, I'm sure, on this webinar are interested in patient blood management, or you wouldn't be here, and have this vision for patient blood management within your own hospitals, institutions, and countries. And now, hopefully, some of the things that these panelists have told us and within the patient blood management themed issue will help you put that vision to action, which is, you know, the next step is that this needs to be an international or global standard of care. So I wanted to ask our panelists some questions, and I'll first start with Dr. Valentine. Dr. Valentine, thank you for that excellent talk on the taxi cab guidelines, and also to highlight your article. You were the corresponding and lead author in Transfusion Strategies for Hemostatic Blood Products in Critically Ill Children, a narrative review and update on expert consensus guidelines in our ANA themed issue. Dr. Valentine, I wonder if you could comment. Certainly this provides a much needed gap, giving expert consensus or evidence-based, when they're available, guidelines for restrictive administration of these hemostatic products, FFP and platelets, but also, you know, cryoprecipitate, maybe fibrinogen concentrate, or prothrombin complex concentrate. So I wondered if you could first tell us a little bit about the next step, plans for implementation of the taxi cab guidelines. I think you're muted.
Thank you, Stacey. Yeah, so the next steps, similar to the Transfusion Anemia Expertise Initiative, which was first for red cells, we have a large implementation process for taxi cab. And so we're very excited to have implementation scientists who are on board during the creation of these guidelines. And looking at, so the most important part about creating these is that to reduce transfusion-associated complications, and that's the entire point. And so as we implement them, we're actually studying the implementation of these in a systematic approach. And we've just completed an RCT looking at that for the red cell transfusion. So the plan is to do this for these as well, to really inform us of how it's changed practice, and then also to inform us of where we need further research.
And also, I would put it that really what we need to do is decrease variability in care. And hopefully following these guidelines will give individuals, practitioners, a means to decrease variability in care. So thank you. I'll go next. Dr. Hare obviously is not here. He couldn't make it, but I would love to introduce the lead author on the article, On Track, a 20-year history of successful coordinated province-wide patient blood management programs. And that's Dr. Katerina Pawensky. So thank you for joining us Dr. Vivensky. You are head of the Division of Transfusion Medicine, a clinical hematologist, and a co-director of patient blood management at St. Michael's Hospital in Toronto, and associate professor in the Department of Laboratory Medicine. So it's very nice to have you here today. And I wondered if you could just expand a little bit on, what are the lessons learned? Because I think taking all of our visions into actions and establishing a patient blood management program in one institution is daunting, let alone, the 20-year history on your hospital programs throughout the province is really, I'm sure you have a lot of lessons learned that you could share with us. Unmute, yeah. I think maybe the host needs to unmute.
There we go.
There
Yes,
you
the
okay.
host needed to unmute me. Thank you.
Thank you.
Well, thank you so much for allowing me to answer the questions. And again, please accept apologies on behalf of Greg for not being able to be here. So in terms of lessons learned, it's a difficult question. I think the most important operational lesson is, in retrospect, I would, if I had to redesign the program all over again, I would have concentrated on hospitals with identified MD champions. Cannot emphasize this enough. You can put in absolutely excellent nursing in, but unless you have MD backing, and it's usually anesthesia, transfusion medicine, hematology, it's very difficult to accomplish anything. And because the way these hospitals were originally selected was based on their blood usage rather than will these nurses be able to be successful and achieve the potential, it was a very different take. And I think over the years, we've come to realize that nurses in hospitals where there is more of a PBM culture and there is support of the champions, they achieve substantially more than the ones who do not have that. On the other hand, it's a philosophical question. Maybe those are hospitals where we actually do need to keep pushing and changing things. From more sort of scientific research perspective and QI perspective, more robust data collection is something that I think is phenomenally important for these programs. It's nice to show associations, but if you were to ask me very specific deep dive questions about, for example, which specific patient population you want to address, or what is the incremental benefit of adding TXA to, say, erythropoietin, et cetera, it's very difficult to tease this out. And so, but ideally, this is something that we want to do because as our practice evolves, as science evolves, we need to be agile and adjust the treatments that we have selected. So those are the two. There is tons more, like putting emphasis on primary care, so the anemic patients don't come to us, 3 days before surgery with severe anemia that has been going on for years. Patient education, because I would argue that we still don't know how to best reach our patients and make them advocates for themselves. Anyways, just to name a few.
Yes, I mean, all great ideas. I wish we had an hour to talk about it. But certainly patients are becoming more advocates for their own care. And I think that's a really important part of patient blood management. We have a really nice a couple of articles written in our themed issue just about that, the ethics of patient blood management and how patients can be advocates. There is a lot of questions on preoperative anemia management and treatment. And, we sort of go back and forth between, is preoperative anemia a low-hanging fruit or is it a high-hanging fruit? Because it's hard to manage and recognize and treat. And not only that, there is an association between preoperative anemia and increased morbidity and mortality. There's association between transfusions and increased morbidity and mortality. And one of our participants asked, you show an association between morbidity and preoperative anemia, and yet now we were tolerating significant anemia in our patients by avoiding intraoperative transfusions, even in patients who start with maybe a normal. And so I guess that question is all about now, anemia throughout the perioperative period and what's the risk? How aggressively should we treat preoperative anemia, given that we're tolerating restrictive strategies now and doing other multimodal? Because certainly in the United States, it's very expensive. I wonder if you could just comment on that. I think you're muted again.
Oh, again. Okay.
Okay.
Thank you. So you may have gotten a slightly different response from Greg than it is from me. And I do understand that I am a hematologist and a transfusion medicine physician surrounded by anesthesia. And it's not a big surprise that Greg is a proponent of liberal transfusion in very specific patient populations with cause, because we do have some evidence to suggest that patients with cardiovascular comorbidities and those who are elderly may be slightly different from our run-of-the-mill patients. So my answer to all of this is that it's a question of Goldilocks. We know that anemia is bad, transfusion may be bad. How is transfusion? Well, we've talked a lot about how anemia is bad. Well, there's lots of evidence to show that transfusion is associated with poor outcomes. And why is it? Well, we have no idea. People spend their entire careers trying to figure out, is it the microparticles, the iron, is it the donor contributions, the age of blood, et cetera, et cetera. The point is, it is associated with adverse outcomes. So back to the Goldilocks. I think it would be unwise to say that restrictive transfusion thresholds are correct for every single patient in front of you. And it is a balance, just as Greg said. It's a balance between managing anemia and also managing anemia with transfusions. So in some circumstances, and there are lots of studies that are coming out, and maybe I will make me wrong tomorrow or the day after tomorrow, but we may find that for some patients, we perhaps should not be tolerating very low hemoglobins intraoperatively. But I would also argue that it is very, very difficult to show what is the cause, because anemia in itself is bad. Transfusion does not seem to be always the answer, but may be the necessary evil for some of your patients. So I hope I answered it in Greg's spirit. But I'm sure we can, that would be a sort of a journal club on its own to discuss how low should we go and in what patient populations this is appropriate, in what patient populations it should not. But again, every patient is different. This is why we're physicians, and this is why we should be taking into account the clinical context and the comorbidities and making those decisions appropriately.
Absolutely, I couldn't agree with you more. One size does not fit all. And now we're into where medicine and anesthesia is evolving into precision medicine. So an individualized patient-centered approach is exactly what you're saying. So definitely, thank you.
And hemoglobin may not be the answer. Sorry, Susan. That's one other thing, is that maybe what we really need is some other ways of measuring the need for anemia management.
And definitely, we need physiological markers. Exactly, I agree with you, and so thank you. I wanted to point out one thing. I think as a patient blood management advocate, I need to point out the difference between patient blood management and optimal blood use for our audience. In our ANA patient blood management special themed issue, we have the new global definition of patient blood management, and it is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving the patient's own blood while promoting patient safety and empowerment. So it's harnessing the power of the patient's own blood, whereas optimal blood use, OBU, is different. That's actually, using blood products or components in optimally. And so there's two different things. Certainly a measure of your patient blood management initiatives would be progress in optimal blood use. So I need to kind of make sure everybody understands the difference because I think it's important. But now we'll move on to tranexamic acid, one of my favorite topics. And I want to thank the two speakers who really nicely highlighted tranexamic acid in cardiac and also trauma, which are two difficult and very different considerations. I think everybody now, Dr. Patel is talking about the POSI trial that just came out in patients undergoing non-cardiac surgery, as you highlighted, where the incidence of composite bleeding outcomes was significantly lower with TXA than placebo. And I just wanted to get your thoughts about expansion of tranexamic acid across other areas, non-cardiac cases. I wondered if you could comment on that, given our review article, and then with the new results of the POSI 3 trial.
Yeah, absolutely. So as I focused on cardiac on today's summary on our webinar, I did mention POISE 3, and it is a pretty significant trial. We should discuss it a little bit more because it is going to potentially change the way we use TXA in the peri-op setting. We're talking about expanding to all comers, every case giving it TXA. And as we mentioned, the summary was that it leads to a significantly decreased bleeding event risk rate at 30 days when you give TXA compared to placebo. But then one of the things that we have to ask ourselves is statistically significant versus clinically significant. There are a lot of general surgery cases, non-cardiac surgery cases where bleeding risk isn't that high. I think there was one of our questions in the Q&A that mentioned even for orthopedic surgery, they're already optimized and losing very minimal blood, 150 mLs max. And then if I have a statistically significant difference, I go down to 100 from 150, and it leads to a significant p-value. Does that really make a big difference? It's not clinically significant. So I think that's something that's going to have to be looked at even a little further as we go back and analyze that trial some more to see what particular cases benefited the most. Because we still consider vascular surgery, bigger cases like that, maybe a little bit higher risk in the general surgery population. But then if we're talking about a lap chole, do we really need TXA in a lap chole? The other thing to keep in mind with that trial is that they still did not show non-inferiority. It was a 0.3% difference in the risk of adverse events, but it was not non-inferior. So it suggests that there still is some risk with using TXA. So if we're going to expand it to general surgery, we have to keep that in mind, that it still hasn't been shown to be equivalent as far as safety.
And further to that, could you comment on, we're talking about precision medicine and individualized patient-centered approach. Certainly I am very interested in the pharmacokinetic profile of TXA and really, being able to use pharmacokinetics to simulate a model and get ideal dosing. But also I was just wondering, how could we work towards individual dosing recommendations for TXA patient-specific wise? Could you comment on maybe using viscoelastic testing or testing patients for fibrinolysis or certain things like that? Do you have any thoughts about?
Yeah, I think we're not there yet, but it certainly needs further investigation. There's been suggestions already to try to incorporate viscoelastic testing, especially in the trauma population, as Dr. Wyrobek mentioned. We have a lot of patients that actually don't demonstrate hyperfibrinolysis, and trying to use, whether it's TEG, ROTEM, lysis criteria to try to determine who actually is going to benefit from this. And so trying to incorporate VET, one of the concerns with VET is that right now, if you look, I'll use TEG as an example, LY30 of 7.5% is considered hyperfibrinolytic, but we rarely ever see anybody get that high. And so you'll see a lot of studies will actually use like 3 or 3.5%. So I think we need to better define what cutoffs should be used to say this is a hyperfibrinolytic patient. There's been talk about trying to correlate it to D-dimers. I mean, it's easier said than done, but then you're just trying to send off a D-dimer is not a very quick thing to do, especially when we're talking about a trauma patient and you don't have that kind of time, given some of the summaries that she mentioned of trying to optimize dosing and giving it within 3 hours of the initial insult. But trying to get to patient-specific dosing, I think that's something that still needs a lot more work, but that's probably the next steps.
Thank you, Dr. Patel. And that leads me to Dr. Wyrobek. Thank you for an excellent presentation. I think TXA in the trauma setting certainly, after the CRASH 2 trial, we were giving it, to everybody, at least within 3 hours was beneficial. And there was a lot of push towards having that in the clinical setting. More recently now, there's been a couple of pre-hospital administrations of TXA studies. And so I think TXA and trauma is something we're all, looking at and hoping more studies come out. But I wonder if you could comment on, the administration of TXA appears to be beneficial in the early stages, but then those 2 most recent trials in pre-hospital TXA administration didn't significantly demonstrate a change in outcome. What are your thoughts on those?
Yeah, interesting studies. And I believe the ones you're referring to, there was a hemorrhage study out of University of Pittsburgh, and then there was a TBI study out of Duke. And they both looked at pre-hospital administration of TXA with fairly neutral results in both of the studies. And really, I think, especially in the trauma literature, it comes down to patient selection, right? When you look especially at that hemorrhage study, only about 20% actually needed a transfusion. When they looked at whether these patients had hyperfibrinolysis or not, you're talking about 15 to 20%, maybe up to a third, I think in the PIT trial, really showed that these patients needed TXA. So again, when we look forward, we really need to look at which patients we are selecting. And just as Dr. Patel said, we need to find a better way, whether it's rapid tag or ROTEM, to guide our management rather than one treatment to fit every single patient.
Thank you. So I think we're out of time, and we could talk about this all day. Patient blood management, I would summarize, is now becoming a standard of care globally. And, we've highlighted a lot of really interesting ideas and themes and modalities in our patient blood management issue in ANA September 2022. I would encourage all of the participants of this to have a look at that article. There's some really great informatics. If you're interested also, there's a couple of podcasts that are on the Anesthesia and Analgesia website. And so I would just like to encourage you, don't get overwhelmed, start small, make baby steps. You're not going to have an on-track Ontario, Canada program, but maybe you could start by identifying patients who might benefit from tranexamic acid or anemia management, or pediatric patients who you could use the evidence-based or expert consensus guidelines to guide transfusion, or maybe to guide non-transfusion. So with that, I would like to say thank you very much to all the panelists and participants, to Anesthesia and Analgesia for allowing me to coordinate this patient blood management issue and this webinar, and have a great day.